As you heard before today, probably the best from a surgeon viewpoint is a transesophageal echo. Because in real time, you can take it to the operating room, you can see what we do and the effect of it immediately. Scanners are extremely important, as the previous speaker mentioned to you. Not only can see the entire aorta, but now more and more, they are also getting information on the function. And MRI is one of them. If you cannot quantitate regurgitation very well, MRI is able to do better than echo. There is every single disease of the ascending aorta is connective tissue disorder. Is the media that change in degenerative disease, atherosclerotic, tuberculosis, syphilis, that we don't see anymore, but was there. All the inflammatory disease like Takayasu, arteritis, is all connective tissue. And also the congenital ones. Just to give an example, only in the past 5 years, we thought supraortic stenosis was an inborn error. Inborn error, what is that? I mean, your baby was formed, your sperm was malfunctioning, or the egg was malfunctioning. No, it's a molecule defect. And the defect was discovered that they have systemic elastin arteriopathy. It's not only a supraannular hourglass deformity, and it's specifically one gene. The blood cysteine mood change, your child is born with supraannular aortic stenosis. Likely one day, every single disease will be defined like this one here. One single amino acid didn't come in its proper sequence and cause the harm that you see clinically. For instance, in degenerative aneurysm, they say in aorta, the old folks remain a problem. Is that our gene mutates as we get older because we smoke, we're hypertensive, we are too high low density lipoproteins? Likely that the environment is such that can change our genotype because of influence of the phenotype. So those that smoke, hypertensive, have higher lipidemia, eventually the genes that modulate the arterial wall replacement, the elastic fibers, dies or is altered, and we start getting dilatation, they say in aorta, without a single type of genetic identification. Younger patients, however, most of them now is becoming increasingly more common to be well-defined. And there are 3 general groups. The early Dunlos, that doesn't affect cardiac very much, is more mid-sized arteries, but they can affect the aortic root as well and the aortic valve. This is the best known one. In the past 8 years, when Lewis was in Hopkins, they came up with this new syndrome, which is really a variant of Marfan's, a more severe form of Marfan's. Doesn't affect fibrillin 1 as much, but the transforming growth factor that modulate all tissues express itself much more severely and early on in life. The one described in Netherlands, the aneurysm osteoarthritis syndrome. The transforming growth factor aneurysm. No other abnormality. The also arterial tortuosity. And finally, the patients with excessive elastic skin. And then the familial aneurysms that can be only ascending aorta or descending thoracic aorta or the aortic root. They all have genetic component. And finally, the mutant, one that appears from time to time. It's interesting because in most of them, a gene or genes have been identified. It's well known in early Dunlos what gene is abnormal. In Marfan's, it's a gene that modulates fibrillin 1. In early Dunlos, transforming growth factor beta 1 and 2. Gibrin edited an issue that we all should be reading on the Annals of Cardiothoracic Surgery last month. Has a very comprehensive review of the genetic abnormality that affect the the aorta. And Bakker, the author of this paper, has this beautiful slide represent all the transforming growth factor beta alterations. So one group of genes that can affect the other genes and produce aneurysm. The most fascinating ones are those related to Marfan syndrome and Lurich syndrome. It's fascinating to see the pharmacology of the cell, how the molecules change and cause the phenotype that we all know and take care of them. I don't know if a heart surgeon should know very much about which kind of receptor complex beta blocker needs to be functioning or not functioning to produce. For instance, JITS is trying to block this reaction here by giving a losartan in infants. If they are born with Marfan syndrome, for the first 2 months of life, they're randomizing children with losartan or not. The results are not available yet. He knows that in rabbits, in the uterus, you prevent Marfans, prevent the genetic expression. If it's possible to do after they're born, we don't know yet. Doesn't look very promising. It's not as simple as blocking one receptor only. It's a much more complex. Being ignorant, my approach is more sick. This is God. This is the essence of life. Are we going to ever be able to control every single reaction to produce a perfect subject in the end? I doubt very much. We'll be able to understand the many pathways, but not all of them, only because of its complexity of our genome. I told you these like guidelines, but guidelines being published every day, and I'm not so sure who was behind all this, because they think we're all stupid, we are dangerous, we need laws and regulations, but then the laws and regulations becomes dangerous too, because you give the less qualified practitioner a justification to do things that he may not be qualified to do. You have to know how to diagnose Marfan syndrome. It's very prevalent. 3 in every 1,000 of us will have Marfan syndrome. And the typical Marfan syndrome is no more. You don't have to be 6.5 feet tall. You don't have to have very long wingspan and over-elastic joints and dislocated lenses. The experts in the syndrome met again in Ghent 3 years ago, and they redefined the criteria for Marfans. And I think you have to read this paper. If you are a cardiac surgeon, the deal, make a little table in your office, what the revise meant. What they did really was to take all the genetic knowledge over the past 10 years and put in the old classification. If you remember in the old classification, there were major and minor appearance of Marfans. For instance, is every basketball player Marfans? But they are 7 feet tall. Well, not necessarily. Being very tall is a minor feature Marfans. Being very tall, to have a wingspan, over that foot, pectus, you start adding multiple skeletal abnormality, they might become Marfan. Is found abnormal then. Basically what they have done, they took 4 major criteria. Dislocated lenses is a very important one. Aortic root aneurysm is a very important one. And durectasia. And then if you throw in 4 another abnormalities, this is Marfans. Or any of them alone with the genetic proof that they're abnormal. So it became much more inclusive. And not all our patients. Many Marfan patients now is going to neurosurgeon, orthopedics, or the ophthalmologist because they don't develop necessarily aortic root. Those we care are those that really come to us for attention. And indeed, they become much more inclusive. If the aortic root is twice as big as the normal size, normal average, size, and they have problem in the lenses, smart fans. Twice as big as there's any test of fibrillin abnormal. Only the aortic root dilatation, plus a gene, smart fans. If they have dilatation of the aortic root in any system manifestation by points, like over-elastic joint, the pectus excavatum, or pectus carinatum. If you add them 7 points, Marfan's. And of course, then one group that you and I don't see is those who had lenses problem and fibrillin abnormality, Marfan's as well. So the new criteria is much more inclusive. Cardiac surgeons, unfortunately, have to know a bit about this. Why is it bad for those who have aortic root aneurysm? Well, Marfan's is one of them that rupture fairly early, can dissect, and if they're lucky enough to survive this or not to have this, eventually they develop aortic insufficiency because of dilatation of the aortic annulus. The guidelines, again, tells for surgery at 50. Well, there's no documented rupture at 50, unless they have family history of dissecting aneurysm, or if the woman is pregnant. So why to operate at 50? Well, operate at 50 because a guy called Taron Dave came up with the idea of repair the valve. Don't give them a mechanical valve anymore. And everybody jump in this bandwagon or premature repair. Or it is better to repair a small root than a big root.